Good evening, everyone, and happy Trigeminal Neuralgia Awareness Day. We hope that you all were able to spread awareness somehow today, whether it be through social media, just wearing teal, or passing out ribbons. And what better way to celebrate Trigeminal Neuralgia Awareness Day than to have a webinar? So tonight we have Dr. Jeffrey Brown, who is chair of the Medical Advisory Board, who will be giving us top 10 things that you should know about your diagnosis and its treatment. So you may submit questions throughout the webinar, but we will answer all questions or try to answer as many questions as we can at the end. Thank you.
So good evening, all. The actual title of what I'm going to speak about is trigeminal neuropathic pain. Note that. And so, yes, it's going to be like downtown, top 10 things you need to know about its diagnosis and treatment. Trigeminal neuropathic pain. So, 10 principles, beginning with number 1. There it is on your screen. The physician treating what I'm going to call trigeminal neuropathic pain should be competent in all the accepted means of treatment, both medical and surgical. In other words, a doctor who has a hammer only knows how to use a hammer, though he may be very good at using that hammer. The problem is not everything succeeds at first, or the way you expects it to succeed. So if it doesn't, what's next? It could be something else, but can the same doctor handle it, or is he going to pass you off to someone else whom you don't know? So the best situation is if your doctor can treat multiple different ways your trigeminal neuropathic pain. Number 1A. It is my opinion that this thing, which we'll talk about, called microvascular decompression, brain surgery for trigeminal neuropathic pain, is a special procedure that only should be performed by a neurosurgeon who has extensive experience, not the I did that once, maybe I could do it again kind of thing. Is this doctor extensively experienced, as are all the neurosurgeons on the Medical Advisory Board? As a codicil to that, if your surgeon doesn't have the ability to continue the effort to make you pain-free, if the operation done isn't effective, as it sometimes is not, and we'll talk about how often that can happen, then that may not be the best surgeon for you. Notice I'm being definitive here, but these are top 10 things. And as the photograph shows in the bottom left, you may have to continue your search for help. So all that is number 1. Number 2, let's not talk about this thing called trigeminal neuralgia. It's confusing. And lots of people are confused. Is this typical, classical, atypical? What's wrong with the term trigeminal neuralgia? Let me show you. I'm going to do that by using the term trigeminal neuropathic pain, meaning pain that comes from a nerve. What nerve? The trigeminal nerve. The nerve that provides you sensation in your face is the trigeminal nerve. So here's a picture, nothing to do with the trigeminal nerve. It's a very clear, distinct image of a collection of steel pieces. They're all quite distinct and sharp. But there's another side to that. If you look at it from behind, where the light has been shining on it, you see a more quiet shadow. They're both sides of the same thing. The way trigeminal pain can have multiple sides and multiple elements to it, not just the sharp pain, but there may be an underlying shadow beneath it. It's an analogy, which is to say, facial pain isn't purely one thing or another. Let me explain. I use this thing called the McGill Pain Questionnaire, which has multiple words. Some of these words on the left fall into categories that describe something called paresthesias. What are paresthesias? They can be grouped into spatial paresthesias. Are they jumping, flashing, or shooting pains? Or punctate pains, pricking, boring, drilling, stabbing, lancinating. You've heard that word if you know anything about trigeminal pain. Or incisive, sharp, cutting, lacerating. They all describe sharp, electrical-like pains. There's another group of words which I call dysesthesias, meaning odd feelings. They're first grouped into those that are temperature related, hot, burning, scalding, searing. That's in order of the severity. Or in terms of the brightness of the pain, tingling, itchy, smarting, stinging, more severe. Those are all pains associated with nerve injury. They're words that people seem to understand that describe nerve-generated pain. Neuropathic pain is nerve-generated pain. On the other side, there are terms that describe what is called nociceptive pain. That's the pain you get classically if you get a cut in your hand, if you get punched in the nose. The words you use are dull, sore, hurting, aching, heavy, or pinching, pressing, gnawing, cramping, crushing. Those are words that are used when a nerve picks up injury to the tissue in your body. It's what nerves normally do. You get an injury, there's inflammation, and the nerves pick up that inflammation and get back to you, and you use those words to describe it. The thing about trigeminal neuropathic pain is that all those words come to play in describing the pain in the face. So what I try to say is, if you have pain in your face and it's got a predominance of those electrical things, paresthesias, then you have neuropathic facial pain that's predominantly stinging, lacerating, cutting, or it's predominantly paresthesias. But there may be other pains associated, which are these dysesthesias. They may also be mixed in. These dysesthesias, odd feelings, are usually constant, whereas the stinging paresthesias are intermittent. So people with facial pain that's neuropathic can have a mixture, which is why we have problems describing this trigeminal neuralgia thing, because it's really a mixture of pains. So here's an example. It's an operative image. We're looking in the brain of trigeminal neuropathic pain in a patient with paresthesias, meaning stabbing, intermittent pain, which comes from an artery compressing the nerve. You're looking at the brain now under the microscope. This is what a surgeon would see. So this is the trigeminal nerve. You can see how those arteries are punching in to the trigeminal nerve. There's an instrument trying to hold it away. So this is the trigeminal nerve. There are those testy arteries causing the stabbing pain. But trigeminal neuropathic pain can also occur from a vein. So here we're looking at a picture. That's the trigeminal nerve inside the brain. The brainstem is here. The face is out here. There's a piece of cotton there, but let me show you this video. This is the nerve. See this vein? It's stuck into the nerve. And this instrument is coagulating that vein to get rid of it. slowly. No, it's okay to move the nerve just a little bit. So the vein's been coagulated. That's the remnant of it. And it's okay to cut veins for the surgeon, not arteries. You'd get a stroke, but you can cut a vein and get it off the nerve. You can't tell, but these other little red things are veins that are not touching the nerve. So veins can cause trigeminal neuropathic pain inside the brain, as well as arteries. Now, here's an advertisement with this happy woman. I don't know why they would show a happy woman who has burning mouth syndrome. What's that? Well, it says doctors and dentists don't have a specific test for burning mouth syndrome, which makes it hard to diagnose. There's a reason for that. And there's no specific treatment that works for this. There's a reason for that. And what's that? All right, so here I'm being definitive again. What is the definition in my judgment of a syndrome? It's a series of words of no help to you, the patient, whatsoever. What the doctor is saying is, you have a syndrome, which translates as, I have no idea what your problem is, but if I give it a fancy name with several hyphenated other doctors' names included, you'll think I'm very smart, but it doesn't help you. So if the doctor tells you you have a syndrome, that's of no help because there's no treatment for it. Now, many of you will be asking, do I have typical or atypical trigeminal neuralgia? And here's my definitive statement again. If someone says your pain is atypical, all that means it's not typical to the person making the diagnosis. That physician may not see it often. So he says, or she, it's atypical. But that doesn't have anything to do with your health problem. So I don't use those terms. As I said before, patients with nerve-generated facial pain, neuropathic facial pain, will almost always, if you give them these lists of words, have a mixture of the nerve pain and the non-nerve pain. So, and this is an actual patient's checklist of a patient with trigeminal neuropathic pain. They use the word flickering. Flickering is a not neuropathic. It's a nociceptive kind of pain. Pounding, beating, those are all not nerve-generated pains. But then there's the shooting pain, which is neuropathic. There's the stabbing pain, which is neuropathic. Sharp, stabbing, shooting, those are those paresthesias. But then again, on top of that, there's this nociceptive element, crushing and pulling. And then once more, there's this other nerve pain, tingling. But it's mixed in with hurting and mixed in with this other tenderness, rasping. So it's confusing. There is no clear single set of words that people will use. Not that it's confusing to the surgeon, but it's not so easily clarified just by talking. You need to see all the kinds of pain and get a sense of what's predominant. In this case, the patient would say the predominant pain is the stabbing, shooting, and then there are these underlying pains. They can't be ignored. They're part of the syndrome. We're only up to number 3 now. Now, number 3 is, how are we going to treat this pain? And it's with medicine. And the statement is, despite what your doctors, neurologists, primary care doctors will start doing, there is only one approved medication to treat this trigeminal neuropathic pain by the FDA, the Federal Drug Administration. Only one. This is the carbamazepine or Tegretol. Now, that's not always the first medicine people use, but that's the only one that's truly approved. The other ones that are often used are something called gabapentin or Neurontin and oxcarbazepine or Trileptal. And they're okay too, but technically they're not approved. Many of these medications, to make them more expensive, will have XR attached to them, meaning extended release. And to my understanding, I have never read a paper that says there's any advantage to taking extended release medications in terms of treatment results. Or often people are now being prescribed Lyrica, which is approved for use in diabetes for people with pain in their legs, but it's not approved for use in trigeminal neuropathic pain. So the mainstays are the Tegretol, gabapentin, Trileptal. And don't use opioids for trigeminal neuropathic pain. But people will say, I get some benefit from it. And the answer is, these nociceptive pains that are mixed in with trigeminal neuropathic pain may well respond to opioids, but not for the trigeminal neuropathic pain. Not for trigeminal neuropathic pain, meaning stabbing, lancinating, tingling pains are not treatable by opioids. The underlying other pains may be. Also, when does one say medication has failed? My judgment is if one has been properly treated with what are called titrated doses of at least 2 different anticonvulsant drugs, and they cause poorly tolerated side effects, usually sleepiness, clumsiness, falling, and they don't adequately reduce the pain, the medication has failed. What do I mean by titrated? You can't start at a high dose of these seizure medicines that are used. The gabapentin is a seizure medicine. It reduces the amount of electricity that gets to the short circuit in the nerve, and I'll talk about that. But if you start at a high dose, you'll get side effects that are unacceptable. So the dose has to be started low and then gradually raised. Along that, many doctors will say, well, this drug isn't working, so we're going to add a drug, add a third drug, sometimes add a fourth drug. I know of no proven benefit from using multiple drugs. Some people may get better, yes, it's true, but there's no proven benefit from multi-drug regimens. Also, some people may get specially put together facial creams to rub on their face. And once again, there may be some benefit to it, but there's no proven benefit to any of these fancy and ultimately expensive regimens. If the mainstay drugs aren't working, then we have to look at some other treatment, which is usually, or needs to be, some form of surgery. What if it's an emergency, where the pain is so intolerable, you can't eat, you can't drink, you can't talk, you can't take it anymore? It is possible, under guidance, to visit the emergency room, but you would need to do it with a physician who knows about this and receive an infusion of another anticonvulsant drug, Dilantin, over the course of a number of hours while your heart is being monitored for side effects. You get 1,000 milligrams or 1 gram of this medicine, and it should temporarily control terrible stabbing pains, at least until something else can be done. Something else needs to be done, however, because the pain will come back, but this will calm it down when it's intolerable, and you don't want to have an emergency operation. There's rarely an indication for that, but you need to stop the pain. The emergency room is capable of doing that, not with opioids, not with morphine, not with Dilaudid, but with this thing, Dilantin, another form of seizure medicine, to be given intravenously with careful heart monitoring. That only takes me up to number 4. At the bottom, I'm being definitive. you must, if it's possible for you to have an MRI of your brain with careful software added called the CIS, Vibe, or Fiesta software in 3 different planes to look at the trigeminal nerve. If you don't have a study like this, it won't be helpful. What is this showing? This picture is showing this thing, which is the trigeminal nerve. The face is out here. The trigeminal ganglion is here. And the nerve is going into the brainstem here. And the arrow points to this artery lying on top of the nerve. It can be plainly seen. The white is spinal fluid. This is from the side. If you're looking straight on, straight at the face, this is the brainstem. The white is spinal fluid. This is the trigeminal ganglion in here. This blob is that trigeminal nerve in cross-section, this, and there's the artery on top of the nerve. It can be plainly seen. And if you look at it with cuts from the top of the head to the bottom, there's the brainstem. The nose is out here. The trigeminal ganglion here. There's the trigeminal nerve. And this sausage is this artery, is this artery. You can plainly see what's the problem is. What did I just do? So, all MRIs are not equal. If your doctor's sending you for an MRI and saying you're going to get the most powerful 3 Tesla MRI there is, that doesn't make a difference. What does is how intelligent the radiologist is who's doing that study, and if is he using the correct software to get to the right image. Because you're getting an MRI so a surgeon can tell you what to do if you need surgery. And if your surgeon cannot show you on your MRI this precise point of contact of a blood vessel on your nerve, then you should not be having surgery. The surgeon should know exactly what he's looking for. There's no more exploratory neurosurgeon needed in trigeminal neuropathic pain surgery. Here's an MRI. There's the nerve. There's the artery. In this case, you know exactly what you're looking for. What's this look like in a cadaver? This is the brainstem here. This is the trigeminal ganglion. This is the trigeminal nerve. The black area is where spinal fluid is. There's that artery lying on top of the nerve. That's what it looks like in real life, or at least cadaver real life, which isn't real life. Doesn't have to be an artery. It can be a vein. In this case, the brainstem is here. This is the trigeminal nerve, and here's a vein, at least in a cadaver, lying right on the trigeminal nerve. Back up. A word about something called glossopharyngeal neuralgia. The glossopharyngeal nerve goes to your throat. It's a sensory nerve to your throat, and it's possible to get stabbing pain in the throat. It's not a topic that we discuss a lot, but it's possible. And in that case, one can image this thing, which is the glossopharyngeal nerve, with an artery lying on that. And an artery can cause the same kind of stabbing pain that you get in your face. It can be in the ear or in the throat. So they're both caused by arteries, usually arteries, but it could be a vein lying on the nerve itself. It can be visualized. There's no guessing. Once again, if you see a neurologist and he orders an MRI or she orders an MRI, says we need to have this to make your diagnosis of what I call trigeminal neuropathic pain, you have to have the MRI with this technique. Or ultimately it's going to need to be repeated and done correctly, because it won't be helpful. Will it show anything? Yes, it can show if you have a brain tumor, but even then you'll still need this study, because as I'll say, brain tumors alone don't cause trigeminal neuropathic pain. I'll talk about it. What does cause trigeminal neuropathic pain? Trigeminal neuropathic pain is caused by a short circuit in the trigeminal nerve right next to the brainstem. It can be caused by an artery or a vein pounding against the nerve till it strips the insulation so that nerve fibers are naked against each other, and when electricity goes through it, the nerve, you get a short circuit because the nerve fibers don't have their insulation. It can be caused by some form of surgical injury to the trigeminal nerve, or it can be caused by multiple sclerosis, which injures the myelin in the nerve. It's a short circuit. It's actually been demonstrated. So here is an electron microscopic image in cross-section of this fatty stuff called myelin surrounding a nerve fiber. There's thousands and thousands of these nerve fibers in the cable which makes up the trigeminal nerve. And this is what it looks like normally. There's a surgeon in England who did biopsies of the cable, the trigeminal nerve, right underneath this arterial loop, which he moved off and then took a small biopsy of the nerve. And then that insulation, the myelin, was looked at under the electron microscope, just the way this is. And the myelin looks nothing like this. It's totally abnormal. It's totally screwed up, to use the vernacular. It's scarred. This artery is injuring the nerve by injuring the myelin so it doesn't work normally, and that's why the short circuits are occurring. So here's the thing about brain tumors. People think, well, you need to look for brain tumor because that can cause trigeminal neuropathic pain. It can, but it doesn't just by touching the nerve. In this case, this is a brain tumor, a benign brain tumor. You can't see the nerve well, but what you see is the tumor is pushing an artery. Right there is an artery, and it's right up against the trigeminal nerve. So what's happening is the tumor is making that artery come in contact with the nerve, and the artery is pulsating against the nerve, and it's the same deal. The artery is causing the trigeminal neuropathic pain. It's secondary to the brain tumor, but the problem isn't just the brain tumor, it's the artery that has to be moved off of the brain, of the nerve. All right, I'm talking fast, but I'm up to number 6. So what's the best thing to do for your trigeminal neuropathic pain? Is it this microvascular decompression? The best treatment is the one best tailored to the nature of your pain. Your physical and emotional health is not your age. It's your physical and emotional health. Just because you're, quote, old, whatever that means, doesn't necessarily affect what the best treatment is nowadays. Number 7. So, what do you mean the best treatment tailored to your needs? Well, there are 2 forms of treatments. There's microvascular decompression, which moves the artery or vein that's causing the problem off of the nerve, and often a pillow is put in between the artery and vein or the nerve to keep it away from it, to cushion it. Or it's possible by making an injury in the nerve, the trigeminal nerve, ahead of the short circuit, to reduce the amount of electricity that gets to the short circuit and turn the switch off that causes the stabbing, tingling pain. Those are called ablative procedures, and they injure the nerve. So this is a graph, sorry to be academic, And on this side are, say, 100 patients that have had a microvascular decompression. And then they're followed from day 0 over the next 20 years. And how many of them are free of pain at 20 years? It looks like about 75% are still pain-free 20 years later. In other words, on day 0, 90 of them have successfully been alleviated of their pain. And if they're followed, another 15 will have their pain come back with the microvascular decompression. That's the result of this guy, Dr. Peter Giannetta, who pioneered the concept of microvascular decompression when he did the first operation in 1967, just over 50 years ago. Now, if you don't have a microvascular decompression surgically, you have Gamma knife, or you have radiofrequency rhizotomy, or you have glycerol. This is what that curve looks like for something to injure the nerve. If you have 100 patients on day 0, 90 of them will be pain-free with Gamma knife or radiofrequency rhizotomy or the balloon, which we'll talk about. But when you look at the patients 5 years later, almost half of them will have had their pain come back. Why is that? Because these operations slightly injure the nerve to make you slightly numb, to injure the myelin slightly, to reduce the pain from a short circuit in another area that's sensitive, but that insulation can regrow. The numbness goes away, the pain comes back in a short period of time. Yes, you can do the operation again, but it will be done multiple times in a young person over the course of their lifetime. That's just a different way of looking at things. There's a dentist in London, Dr. Zak, who looked at quality of life after all forms of surgery. So number 8, the best quality of life after surgery for trigeminal neuropathic pain is achieved with the bigger operation, the microvascular decompression, under appropriate hands. If you're not going to have that, the next best thing to have done for quality of life is a balloon compression. What's that? Let's talk about it. Why choose balloon compression? It's done when you're asleep. That makes it easy. I have a saying that people who are in pain don't like to be in pain to get rid of their pain. So there's no need to get awakened during the procedure. With this thing called thermal rhizotomy, one has to be awakened to test to see that this needle used to heat the nerve is in the right spot, but not with the balloon. The balloon can treat multiple parts of the face with a single compression, meaning that the pain as it is usually is partially in the jaw, partially in the cheek. It can be treated with just one inflation of the balloon, not multiple movements of a needle. There's something unique about the balloon in that it selectively preserves the fibers that go to the reflex that blinks your eye when something touches your cornea, which is good because that means there's less risk of injuring your vision by repeatedly scratching your eye and not knowing it until your cornea is disturbed and cloudy and you lose vision. Because the balloon does not injure the unmyelinated fibers that deal with this reflex, only the myelinated fibers, it should not affect this reflex. Finally, it's not necessary to do anything fancy to image the trigeminal nerve during the procedure. as you have to do with these radiosurgery procedures, which I haven't discussed, but I will, the Gamma knife and the CyberKnife. So it's an easy, quote, procedure that takes about an hour to do as an outpatient. Now, I'm being brief here. I'm not getting a long explanation, but with the balloon, an X-ray is taken. And this is a picture of the skull, and this is the shape of the balloon when it's inflated to squeeze the nerve. It's called the pear shape because it looks like a pear. And it would be a full pear, but there's air back there. So this balloon is located right here. If you remember, this is the trigeminal ganglion. That's the nerve going into the brainstem. There's your artery compressing the nerve, but we're not actually touching it. We're squeezing the nerve here. I'll show you what that means. Now, this is a patient. I'm sorry, it's a cadaver patient. You're looking inside the skull in a real human cadaver. The nose and face is out there. This is what's called the dura, or the covering of the brain, and it's connected to this bone prominence here called the petrous bone. And there's an opening, which is a virtual opening right here, where the trigeminal nerve comes through and goes to the brainstem. This black thing is the tip of that balloon that's squeezing the nerve. I'll show you more. There's the nerve, there's the balloon. What's it doing? This is what the nerve looks like, not in a human, but in a rabbit who had this operation. And if you remember what the normal myelin looks like, here is what's called a small myelinated fiber. It looks normal. If you remember what those round fibers look like, those are small myelinated fibers, but the bigger ones are all messed up. And specifically, here's the little ones. These are unmyelinated fibers. They deal with pain also. These are actually the pain fibers. It's confusing. They are the ones that deliver pain, but they're not the problem. The problem are the injured ones where there's supposed to be myelin and there's a short circuit because the myelin is injured. So these unmyelinated fibers are preserved. They're the ones that make this reflex that blinks your eye. Those aren't injured. And it's still possible to treat the pain. It's another way of looking at a nerve in cross-section. I won't get too complicated. So on the top, this is the equipment, inexpensive equipment used to do the balloon compression. And in the bottom, this is a little fancier box used to take a needle and heat the nerve, called a thermal rhizotomy. So let me show you in a cadaver, not in a living person, what it looks like when this balloon squeezes the nerve.
Of occurrence. In this film sequence in a cadaver, the nerve compression.
Oh, I moved my mouse.
Of occurrence. In this film sequence in a cadaver, the nerve compression is depicted. The nerve can be seen compressed against the dural edge and petrous ridge.
That's the balloon squeezing the trigeminal nerve. There's the trigeminal nerve. And that's what the balloon does when it squeezes it. It injures it. Now, some of you may have heard that this radio frequency thermal rhizotomy is, quote, more selective or more physiologic because it only injures pain fibers. This is a study that I did in a non-human, in a rabbit, where a thermal rhizotomy was done in the nerve, which this is a cross-section of the nerve. And all that happens is there's a hole made in the nerve. There's no selectivity to that. And it's also thought that the thermal rhizotomy would selectively injure pain fibers. But as I said, pain fibers aren't the problem. It's the fibers that deal with light touch, the cool breeze, somebody just touching your face. Those are the things that set off the pain. They aren't pain fibers. It's confusing, but they aren't pain fibers. It's the normal sensory fibers that set off the short circuit that set off the pain. Now, one thing that happens when I squeeze the nerve is it causes a slowing of the heart rate. We're prepared for that. But this is a graph showing what's happening to the heart rate in someone who's having the nerve squeezed. You have to be prepared for that. Never caused a problem, but we're prepared for it. I want to spend a few minutes talking about radiosurgery, CyberKnife radiosurgery. Number 9, radiosurgery has nothing to do with radios. It has nothing to do with surgery. There's 2 ways to deliver radiation to injure the trigeminal nerve. One uses a fixed source of radiation. It's in a box. And when the box is open, there's a cone that delivers a pinpoint of radiation to a specific pinpoint. And that pinpoint is the trigeminal nerve, and one's head is put in a frame and it's lined up so that that pinpoint is precisely where the trigeminal nerve is. The CyberKnife paints the nerve from multiple different directions. How's that? Let me show you. It's delivered by a robot programmed to shoot beams of radiation from 90 different directions to paint the nerve with small doses of radiation. This is what the robot looks like. It moves very slowly. You may have seen pictures of fast-moving robots doing arc welding for car manufacturing, but this one goes very, very slowly. And it can make adjustments for small movements because pictures are taken, x-rays are taken that cross, and they take x-rays of the skull, and those images are fused to an MRI image so that it makes adjustment for small movements of the body and head, and the face is kept in relatively immobile position by a mask. Nothing is screwed into the head as it's done with Gamma Knife. And so on the left, you see a nerve near the brainstem, and the Gamma Knife will deliver one shot of radiation, just one, whereas the CyberKnife will come from multiple different directions and evenly or homogeneously paint the whole nerve instead of just a hot spot. One is not better than the other, they're just different. So I'm up to number 10, and I've kind of moved pretty quickly, but here's my point with number 10. What you should do for your trigeminal neuropathic pain is kind of a mystery, and one has to look through the distant tunnel to find your own way. There is not one way to do it. So I'm hoping by this run through to let you have the best possibility of doing that so that you can have your own highway to that mystery at the other end, which is pain relief. I've got some questions people asked, and I want to answer them. I hope I answer them during the course of the lecture. People are asking about what causes an artery or a vein to compress the nerve. And the answer is, it's the luck of the draw. It's just there, except in the case of the brain tumor where it's been pushed on it. Someone's asking about why do people get tingling? Why do people get stabbing? It's generally thought that the intermittent stabbing is an earlier phase of a progressive disease, which is what this trigeminal neuropathic pain is. Things start off, you have just a small zap, and then it doesn't happen again. Why doesn't it happen again? Because this insulation, the myelin, can heal. So when it heals, the pain may go away for a day, a month, sometimes a year, and then it may break down again because the artery or vein is still pounding against the nerve. So it breaks down that scar that formed or that insulation, and the pain comes back because the short circuit comes back. But then it goes away again because the myelin can heal. But over time, it may get more frequent, and over time there may be constant injury, constant leakage of current, which is this tingling and prickling pain, which is a more significant element, harder to treat. So there has been a study that says if one's pain is present for more than, say, 8 years, and that's not necessarily just a deadline, then it's harder to treat the pain. So this is a progressive disease. It's better to get on top of it earlier than later. Not an emergency, but if it goes on for year after year, it's harder to treat. Again, what I've tried to do is tell you that trigeminal neuropathic pain is all a form of neuropathy. Trigeminal neuralgia is a form of neuropathy. It's an earlier form, actually an easier to treat form, but it's all part of the bigger picture of trigeminal neuropathic pain. And let me see if there's been other questions that have accumulated while I've been talking. Maybe I just talked too much. So Allie, are there other questions out there?
Yes. So at the later part of your presentation, you discussed surgeries. If you had a failed MVD surgery, would you recommend trying balloon compression before having a repeat surgery, or it depends on the case? You would look at an MRI.
I didn't get into that. The question is, if the MVD fails, what's next? What I usually recommend, if a patient who's had a microvascular decompression and the pain comes back, or it didn't work in the first place, is to repeat the carefully done MRI and see what there is to see. Sometimes there may be an artery that was missed, or a loop of an artery that was missed, or a vein that was missed, or an artery that wound up on top of the nerve when you didn't expect it. And if there's any way of seeing that, I would try to. It's hard to interpret an MRI done after surgery, but it's very possible that it can show that there's something still causing the pain. In the absence of being able to determine that, or as a quote easier alternative in someone who's just gone through a long operation, then my usual means would be to consider the balloon compression, because as I say, if an MVD can't be done, the balloon compression gives the best quality of life. There are more details that would have to be worked out in terms of where the pain is, but that's usually how I go about thinking of the problem.
Thank you. And an additional surgical question, is the success rate for microvascular decompression reduced if you had previously had Gamma Knife?
Controversial question. Dr. Peter Janetta, if he was here, would say, yes, it's a harder operation. My personal judgment is it depends. What it depends upon is if the Gamma Knife causes numbness, and the numbness is the problem, then then the microvascular decompression won't help that necessarily. So if the Gamma Knife didn't cause pain relief and it didn't cause numbness and the pain is still there, then my answer is it does not interfere. However, if the Gamma Knife caused numbness and the problem is the numbness from the Gamma Knife, that's a whole different problem. And a microvascular decompression may not even help in that case.
And for some people who may be newly diagnosed, if they are trying to find a physician to help treat them, what are some questions you would recommend people asking the doctor as per se they're interviewing their doctor? So how do they know they're finding the correct doctor to treat them?
Well, everyone knows you ask the physician, how often do you treat this? Doctors may not know how many operations they've done, but they have a gist. If it's 1 versus 500, that makes a difference. And also the question, as I mentioned at the beginning, is, all right, so you're recommending I have this operation. If that operation doesn't work, what other options do you have for me? And if they only have one operation they can do, I don't recommend that's the doctor for you, because you want to stay with a doctor who's expert in multiple ways to treat trigeminal neuropathic pain. In other words, he's an expert in trigeminal neuropathic pain, or she, not just an expert in one operation. So yes, how many operations have you done? What other operations for trigeminal neuropathic pain can you offer if this isn't the right one? And those are pretty good questions.
What if they aren't looking for surgery? What if they are just looking for medication, medical, pharmaceutical treatment?
Right. It's very hard to find an expert in medical treatment of trigeminal neuropathic pain. Usually it's a neurologist, a medical neurologist, but it's very hard to find someone who's an expert in that area. But it's usually a neurologist, not a general practitioner, who knows a bit about it in any case. If you can't, always fall back on members of the medical advisory board, and the trigeminal neuralgia website will lead you to physicians who are at least interested in the treatment of trigeminal neuropathic pain. It doesn't pretend to indicate their qualifications, but it shows you doctors who are at least interested.
Okay. I have more questions, or did you have some of your own that you wanted to answer?
I am open to more questions for a few minutes.
Sure. So you talked about the MRIs, you mentioned a few different names. What specifically makes these MRIs so special, other than their newer technology or the radiologist knows what they're looking for? What makes these MRIs so important in treating trigeminal neuralgia or neuropathic facial pain?
The reason you're doing the MRI is to see if you can find the cause of the pain. Most often it's an artery or a vein compressing the trigeminal nerve. These studies show images that demonstrate brain tissue, spinal fluid, nerves, arteries, and veins individually. So you can see the nerve, you can see the artery or vein, you can see the spinal fluid, and you can differentiate them. Quote, normal MRIs don't necessarily do that, and they also take thicker cuts of the brain, 2 millimeter cuts instead of 1 millimeter cuts. So they may do a cut underneath the nerve and a cut on top of the nerve, the trigeminal nerve, and you may never actually see the nerve. So it's a thinner cut, and it's the software that allows you to see the nerve, the spinal fluid, the artery, and the vein and the brain separately. It's not just the intensity of the MRI. There's this number, 1.5 T or 3 T. T is a Tesla. It's the power of the machine, but it's not just the power, it's the software beneath that makes a difference. Plus, not all radiologists know what to look for. So very often in a, quote, standard MRI, the report will be the trigeminal nerve is not inflamed, it's not enlarged, it's a normal study. When there's an artery compressing the trigeminal nerve, that's not abnormal. It's a normal artery that happens to be up against the trigeminal nerve. So the radiologist will say it's not abnormal. And in fact, it's not, but he needs to, or she needs to say whether that artery is in contact with the nerve, not that it's normal or abnormal. So the radiologist's interpretation, the radiologist knowing what to look for, is important. What if they say it's normal and your neurosurgeon says, well, it's not, here's this artery and the nerve? It was because he knows what to look for and the radiologist didn't specifically look for that. So it's a lot to do with whether the radiologist knows what to look for in the study, as well as how he will structure the study. I hope it makes sense.
And I would just like to point out to everyone that a lot of the questions that were submitted were very specific. So I encourage you to check out our past webinar series on the Facial Pain Association website. We've done different topics. So if your question wasn't answered, please check out the prior webinars.
I'm sure everyone's exhausted, Ali, so why don't we wind up here?
All right.
With a cue to what's coming in San Diego. You want to tell them about that?
Yes, so everyone, the Facial Pain Association is hosting a national conference. It is a 2-day conference. It's hosted at UC Irvine in San Diego. If you're interested about speakers that will be there, you can check out the agenda on the Facial Pain Association's website, and you'd be able to see all different sessions. Yeah, so please check out and feel free to register on the website.
Thank you very much.
Thank you, everyone. And a recording will be available within a week on the Facial Pain Association's website if you missed anything.